Welcome back. The American Counseling Association has explicit standards as it relates to closure, termination, and referrals. When we look at professional issues and ethics in the counseling profession, most often the responsibility falls on the clinician to be aware of these standards and to act in an ethical manner. At the end of this lecture, we will incorporate some client concerns around closure and termination and referral. Today, we're going to have a brief overview of the ACA Code of Ethics as it relates to termination and referral. It conveniently follows the idea of avoiding harm or avoiding imposing our own personal values on clients or other participants so that we are not working on our own agenda. We are keeping the client welfare and their best interests as a priority. Counselors are not to abandon or neglect clients in a counseling relationship. We should be having conversations with individuals about continuity of care. We also need to take necessary precautions to look at interruptions to treatment, such as vacations, perhaps long term illnesses, or if we leave a position. We need to be talking with clients about those types of next steps and what they can expect. And by no means are we ever to abandon a client by simply leaving the counseling agency and leaving the relationship without having a conversation around closure and referral. Closure conversations need to be happening early and often. There are a lot of regulations that say we need to be addressing aftercare planning at the time of intake. So think about that. We are having the assessment with an individual and conducting an intake with them. We should be talking about discharge goals, discharge planning, and doing so in a collaborative manner that's intentional and meaningful. If there is a need to transfer services or refer clients to another practitioner, we need to do so in a way that's ethically appropriate. We need to be having open conversations and ensure that this is in the best interest of the client. Again, we do not abandon or neglect our clients, and we also take reasonable precautions to protect their confidentiality. In the event of a clinician's death, we need to be able to appoint a records custodian so that taking a reasonable precaution, we would plan what's the plan of action. We're counselors, but we're also human. We may get ill. We're looking at retirement. We change positions. We may look at developing expertise and moving on. And in these cases, we also need to look at how to plan to successfully transfer clients from our caseload to other colleagues. And how do we manage the records and ensure that we're leaving things in a good position for the client, excuse me, and then for the counselor or the colleague who's going to be taking them on. Closure conversations, again, need to be happening early and often. We want to continuously review with the individual, and that this is just one step in the recovery process. This is part of their experience, but not their total experience. So we will use case consultation as a way to appropriately prepare for closure. If you're doing case consultation and supervision, we should be talking about progress that the client is making in treatment, any challenges or barriers that still exist that we might be using outcome measures or tools. Maybe the individual has hit some subclinical levels on a measurement tool, indicating that they're in a position to successfully transition out of treatment or transition onto another level of care. So, case consultation is a really nice way for us to prepare ethically. We need to be adjusting our treatment plan and the treatment episode accordingly. If you're engaging in treatment planning and you're actively using some SMART goals, which are specific and measurable and they're time oriented, you're going to be updating your treatment plan and your goals fairly often. The idea here is that we want individuals' strengths and assets and abilities to succeed. We want to see the goals being accomplished. We want to ensure that these goals are also very realistic. We don't ever want to let the treatment plan be stagnant. Oftentimes, therapists get into a level of burnout, and treatment planning just becomes another piece of paperwork that needs to get done. Really use this as a collaborative therapeutic tool and ensure that the treatment episode is moving along in an appropriate way. We need to make adjustments, and as people are achieving their goals, we look to prepare for an aftercare plan and start the client on the process for a successful completion of treatment. We want to continue to emphasize growth and development and challenge dysfunctional thinking around transition. We want to be able to justify medical necessity. Oftentimes, insurance companies are really pressed for how much time they will provide you when working with a client. Maybe they're only going to approve 5 sessions. We need to be of professional mindset and act ethically to justify ongoing medical necessity as it is appropriate. You will have non-compliant clients. Sometimes people are just early in the very stages of change, and maybe they are various barriers to treatment and they're unable to fully commit, or maybe they're just simply not prepared to address the concerns that they have. Perhaps they're ambivalent about change. However, if you have non compliant clients, you're going to continually document the risks and benefits. You're going to be documenting potential, in this case, in case management notes or memos in a chart. As an example, when people are showing or not showing up for treatment, maybe they left the treatment session early, as an example, or they're completely distracted and not adhering to the treatment goals or regimen of the interventions. All of those items need to be documented and addressed in not only the counseling session, but also supervision and help guard from any countertransference or transference issues that may be occurring. If somebody does not show up for a scheduled therapy appointment, we need to be documenting that we reached out to them and how we did so. If any safety plan concerns for that individual are always going to be necessary in attending to what it is that we need to do. We know that we've been dealing with some significant stressors and that we want to reach out to the emergency contacts. In some cases, you may be advised to work with a crisis management agency so that they can go out and do a care check. We're demonstrating that we're acting in an ethical manner and that we're engaging in outreach and attempting to meet the individual's need. If somebody doesn't show up and you've called them and you've gotten no call back, maybe you would like to send them a missed appointment letter in addition to a phone call. Also, if they continue to not return your call, you're continuing to not hear from them, then maybe we send them a pre termination letter. That may be appropriate. The pre termination letter might say that you've missed X number of sessions and we have not heard from you. We're interested in rescheduling with you. Please contact us. We may also outline that we did not hear from them in a certain length of time. And here would be the outcome of that. And that might look like the treatment process is in jeopardy and what we may be doing to potentially close the case if it came to it. The next step would be outreach with a closure letter to notify the individual that we've not heard from you, and as a result, we're moving to close your case. However, clients do have the right to dispute this, so list who in the agency or in the practice they can reach out to if they want to grieve the appeal. Also, we need to include a referral and a resource list attached to these types of outreach letters. Some counties or agencies have a no reject policy. So, despite an individual not showing up, despite outreach efforts, we would not be able to close an individual from our services or close their case unless we receive higher approval, say, from example, a county mental health administrator. So the no reject policy can be very trying for a lot of agencies because the caseload numbers are exceptionally high. And when we hold cases for individuals who aren't showing up, some would argue that we are holding a spot for other people who are seeking treatment and might not be able to get the care that they need and they really want because we are continuing to hold on to that spot for someone else. Counselors have the right to terminate services in situations where safety is a concern. You can see that little guy there, safety first. Ensuring safety of the counselor, the client, and the workplace is always going to be a top priority. If there's any form of abuse, threat to harm, termination may be necessary, and in some cases, termination may take the form of administrative discharge. When terminating a client due to safety concerns, it's crucial to document the reasoning clearly in the discharge summary. Be explicit about why the termination occurred and provide clinical recommendations for future care. For instance, you may outline whether the individual may re enter treatment at a later time, after completing another form of treatment, or when their needs can be addressed at a higher level of care. Additionally, counselors have the right to terminate services if clients fail to pay agreed upon fees. While financial issues are not as critical as safety concerns, unclear communication and documentation are equally important in these cases. When discussing referrals, it's important to emphasize that counselors must not refer or terminate clients solely based on the counselor's personal values, attitudes, beliefs, or behaviors. The expectation is that counselors seek training, consultation, or supervision if their values conflict with the client's goals. Additionally, if a counselor's values become discriminatory or harmful to the counseling relationship or to the client, it is their responsibility to address these issues to prevent harm. Counselors are tasked with respecting diversity and always prioritizing the client's best interests and welfare. This requires multicultural competence to work effectively with clients, honoring their diversity in a non judgmental and ethical manner. When making referrals, counselors must also consider continuity of care. For example, if a client presents with severe trauma, they may benefit from EMDR, eye movement desensitization and reprocessing, but the counselor is not trained or certified in this modality. It would not be ethical to proceed with treatment, and in such cases, the counselor should refer the client to an EMDR specialist and facilitate the continuity of care. This process involves obtaining informed consent from the client and engaging in an interdisciplinary collaboration to ensure a smooth transition. By working collaboratively and keeping all relevant parties informed, counselors can support the client in ongoing progress and maintain ethical standards of care. What we want to avoid is having clients repeat their stories over and over again. This can inadvertently cause more harm. This is why sharing records and ensuring that practitioners review them thoroughly is so important. Many clients have expressed frustration, saying, "Why are you asking me this? Can't you read it? I've already talked about this 1,000 times." And in situations like that, I may say, "I've read your record and I understand what's documented at that time. However, I'm interested in hearing this from your perspective today, and I want to hear it from your voice and ensure that I fully understand your experience so I can best assist you." This approach balances acknowledging the client's previous disclosures while allowing them the opportunity to share how they feel in the present moment. Additionally, it's essential to always work within your scope of expertise. As a practitioner, I encourage you to strive for growth and to continually develop your professional identity, focusing on areas of interest, addressing unmet needs in your field, and pursuing specialization, training, and certifications. By doing so, you not only enhance your skills, but you also better serve your clients and make meaningful contributions to the profession. Quality clinical care, when it comes to closure, referral, and termination, involves in balancing many different factors, recognizing that each case is going to be unique. And while professional standards provide clear guidelines, there will always be a gray area that requires judgment and flexibility. It's important to acknowledge that we won't always have the answers, and that is okay. Our ultimate goal is to help clients succeed. Treatment should be effective and timely, avoiding unnecessary prolongation. As counselors, we must ensure that individuals receive what it is that they need from treatment, and the interventions that we're focusing on are going to foster growth and change. Clients are achieving their goals, and it's appropriate to consider closing their case. If they're not progressing, we should assess whether to adapt the treatment plan, refer them to another provider with expertise better suited to their specific needs. So the question becomes, what does it mean to operate within the counselor box? How can we guide the individuals we serve through processes of closure, termination, and referral in a way that upholds their best interest? These transitions require thoughtful planning, clear communication, and a focus on ensuring continuity of care. By maintaining a client centered approach, we can support individuals in navigating these critical moments while advocating for their ongoing growth and well being. Premature termination in therapy can take many forms, and it's often accompanied by specific client reactions. For instance, clients who are not ready to end their therapeutic journey may display signs of anxiety as closure approaches. While the counselor may feel confident that the client is prepared to move forward, the client may not share the same perspective. One common reaction in premature termination is a rapid relief of symptoms, and this can sometimes indicate that the therapeutic work feels overwhelming or that the client lacks the coping skills needed to engage with deeper, more challenging aspects of their lived experience. In these cases, relief may stem from avoiding difficult emotional work rather than from actual progress. As counselors, we recognize that sometimes healing requires working through uncomfortable things to reach the other side. Clients may also express negative emotions toward the counselor as part of the termination process. For example, some may sabotage their progress or project feelings of anger onto the therapist. In some cases, clients may stop attending sessions altogether, avoiding closure, again, altogether, possibly due to an inability to confront the emotional challenges of ending therapy or of a fear of abandonment. This pattern may reflect unresolved issues related to healthy closure or fears that the therapist will, quote, leave them first. Another aspect of premature termination involves a lack of sustained improvement. Clients may experience cycles of relapse, regression, or stagnation, which can disrupt the process of healthy closure. These patterns require counselors to address the underlying issue, such as self sabotage or fear of progress, and adapt their approach to better meet the client's needs. Counselors can effectively respond to these challenges by maintaining transparent communication with clients from the outset and throughout the therapeutic process. Building strong coping skills is key, as is addressing irrational thinking through techniques like cognitive restructuring or behavioral modification. Counselors can also help clients develop a deeper understanding of their experiences and create an aftercare plan with clear goals, identified support systems, and actionable steps for the future. Rehearsing the closure process can also be an invaluable tool. By role playing potential scenarios, discussing concerns, and collaboratively addressing any anxieties about termination, counselors can help clients feel more prepared and confident. This proactive approach ensures that clients are equipped with the resources and emotional tools needed to navigate closure in a healthy and meaningful way. When a client decides to leave therapy, it's important to agree upon a final session to bring the therapeutic relationship to a meaningful close. This session provides an opportunity to celebrate the client's progress, address any loose ends, and ensure a healthy closure. Success in therapy often means goals have been met, things have been moving in the right direction. However, scheduling a final session helps solidify the transition and gives the client space to reflect on their growth. The concept of an open door policy is integral in this process. Ending therapy now doesn't mean the client cannot return in the future. On the contrary, our hope is that clients feel comfortable coming back if they need additional support. This reinforces the idea that therapy is a resource that they can rely on in changing times. Returning to treatment should not be seen as a failure, but as a courageous step towards continued growth and healing. For example, if someone has worked through anxiety but later finds it resurfacing to the point of impacting their daily life, returning to therapy could be exactly what it is that they need. Coping skills evolve, but life circumstances can demand additional tools or new approaches. Therapy should remain flexible and an ongoing resource, not just a one time event. Follow up is another key element of healthy termination. Reaching out after a client completes treatment, whether 1 month, 6 months, or even a year, can help maintain the therapeutic relationship and offer ongoing support. Agencies often structure follow ups based on the nature of termination. For instance, if a client leaves against medical advice, following up might occur within 30 days. If a client successfully completes treatment, the follow up may then take place at a 6 month mark. If there was a referral to another provider, follow-up may happen 7 days to ensure continuity of care. Consider how and when you might implement the following communications to support clients post-termination. These touchpoints reinforce the therapeutic connection, show ongoing care, and help clients navigate future challenges. Whether they return to therapy or simply reflect on their growth, these steps strengthen the foundation for long-term well-being. Clients often express concerns like, I won't be able to discipline myself after counseling ends, or I'm not completely cured if I have a setback. They may worry that if they experience a relapse, regression, or a significant loss, that they won't be able to handle it and will revert back to old behaviors. The structure and support they had in therapy will be gone, and they fear that they won't be able to manage it on their own. As counselors, it's important to challenge these concerns by reminding clients that these are just thoughts, not facts. We can explore ways to dispute these thoughts and develop more realistic, affecting coping skills. This is a useful approach to discuss the difference between sick and cured, which can help clients recognize the harmful nature of all or nothing thinking. It's important to recognize that our daily well being and healthy uh, thoughts will naturally ebb and flow for many reasons. Wellness is not a fixed state, it's a dynamic process. By shifting away from black and white thinking, we can help clients embrace these gray areas and recognize that setbacks do not mean failure. To further support this, we can encourage the use of self affirmations and explore their support network. Who can they reach out to whenever times get tough? What coping skills do they have in place? Are those skills realistic for handling stress and challenges moving forward? The key is to continue practice coping strategies regularly. If regression occurs, we need to put a plan in place to address it. It's important to acknowledge that setbacks are a part of normal recovery. We can approach these moments with honesty and compassion, reminding clients of the progress that they have made. If regression does happen, we can ask, what did you do when you were faced with similar challenges in the past and you were able to get back on track? This helps clients reflect on their strengths and resilience, reinforcing the idea that they have the skills and the tools to handle difficult times and to continue progressing. To further elaborate, here are some examples of how to address common client concerns. For instance, a client might ask, can you guarantee that I won't become depressed again? A thoughtful response would be, you may experience feelings of depression again. That is something that we need to acknowledge. It's important to be open and transparent and honest that yes, this can happen. A client may follow up with, how am I any better off than when I started therapy? And a therapist could say, you've made progress towards your goals. What do you think that you've learned to help you achieve and make this progress? The client may respond that I've learned to control what causes me to feel depressed, my negative thoughts and attitudes. And in this moment, the therapist could say, what you've learned are tools to manage the frequency, intensity, and duration of the depressive thoughts and the feelings. And it's understandable that you don't want to become depressed again. But the skills you've developed to give yourself the ability to combat those feelings, if they arise, you've got them in your back pocket and you know how to use them. This approach is an example of how motivational interviewing can be used to empower clients. It allows them the autonomy to process their emotions while also enabling the therapist to guide them in reflecting on their progress and further evoking change. This balance of empathy and strategic questioning helps clients understand their growth and strengthens their ability to cope and to move forward. So, the key concept here is ensuring a smooth transition, whether you're handling a referral process or a termination. It's essential to maintain continuity of care throughout, which can be accomplished through warm handoffs. And this could involve personally introducing a client to a new colleague or referring them to another professional. And when doing this, making sure that you have informed consent and engage in a collaborative and respective transfer of care. All right, that's it for today's lecture. I'll see you next time.